الدكتور لينا هو الدكتور ايمان الطنطاوي present to us clinical aspects of ischemia. Clinical aspects of ischemia.
I'm Iman طنطاوى, Assistant Lecturer of Neurology and Intervention Neurology at Sorbonne University. Today I'm going to talk about the clinical aspects of ischemic stroke. First of all, the definition, stroke is rapidly developing clinical signs of local or global disturbance of cerebral function with symptoms lasting 24 hours or longer, leading to death with no apparent cause other than the vascular origin. The stroke is the second most common cause of morbidity worldwide after myocardial infarction and the leading cause of acquired disability. However, they've changed somehow at least 20 years ago because in the developed countries due to the major development in emerging treatment modalities. The stroke risk factors are modifiable and non-modifiable. The non-modifiable include increasing age, male sex, black races, family history of stroke or TIAs, and the modifiable ones include, most importantly, hypertension, diabetes, dyslipidemia, AF, ischemic heart disease, obesity, smoking, as well as the autoimmune disorders, obstructive sleep apneas, history of malignancy, chemotherapy, or hormonal therapies. Getting to the pathophysiology of stroke, over here, when the cerebral artery is occluded, leading to decreased blood flow and decreased nutrition reaching to the brain cells from glucose and oxygen, which are used to produce energy, but the brain cell metabolism is affected, leading to alteration of the cell membrane, leading to necrosis and apoptosis, and inflammatory cascade begins until this. When this cycle takes place, there will be a pool of infarction with irreversible ischemia where the cerebral blood flow was less than 10 milli per 100 milligrams per minute, surrounded by viable tissue which is reversible ischemia that can be still saved through the penumbra. This penumbra by time converts into pool which can be saved. That's why time is brain. The penumbra is a target for the emergent treatments modalities to save it. Many etiologies can lead to cerebral ischemia. One classification for ischemic stroke etiologies is called the TOST classification, which divides the stroke etiologies beginning with the most common one, which is the large artery atherosclerosis, followed by cardio, embolism, small vessel disease, other determined etiologies. The last one, the stroke for undetermined etiologies. The most known etiologies for stroke are either embolic or thrombotic. Embolic include the cardiac source, paradoxical embolism, artery-to-artery embolism. The thrombotic strokes include either the lacunar infarctions resulting from the perforated thrombosis or acute black rupture from stenotic vessel with overlying thrombosis. Also, the arterial dissection and hypoxic ischemic encephalopathy are common etiologies for cerebral ischemia. The cardiac source vary from atrial fibrillation, intramural thrombus, irritation over the prosthetic valves. It always targets the large vessels, commonly in the cardiac system, because the cerebral blood flow 80% goes to the bilaterally to both cardiac systems, leaving only 20% to the posterior circulation. That's why cardiac are more liable to cardioembolic sources. The paradoxical embolism is a venous origin resulting from any right to left shunt, like the patent foramen ovale, atrial septum defect, ventricular septum defect, or pulmonary arteriovenous malformations. Talking to the carotid artery stenosis, the carotid artery stenosis secondary to atherosclerosis can lead to cerebral ischemia either by in situ occlusion of the stenotic vessel by an overlying thrombus or dislodgement of part of the stenotic plaque acting as impulse and closing more distal branch as is shown in the diagram over here with the shear stress. The plaque is dislodged and then may close or occlude distal branch, causing further cerebral stroke. The intracranial stenosis of relatively large blood vessel, either the anterior or the posterior circulation, as shown in the images, mid-basilar artery, severe stenosis over here, as well as the diagram which shows severe stenosis of the internal carotid artery just after the carotid bifurcation. The arterial dissection, which mainly targets the large vessels with most common sites of the ICA, vertebrals, and intracranial dissections, which happens secondary to tear in the intima layer of the blood vessel, leading to the blood entry between the vessel wall layers, making or forming false lumen. This false lumen can obliterate the true lumen, leading to cerebral ischemia. The most believed, most common causes are trauma, hypertension, atherosclerosis vasculitis, or iatrogenic during catheterization of large vessels. It can be presented with severe sudden agonizing headache prior to any stroke symptoms. An important etiology to many of the pathogenic strokes is the carotid web, which is often missed. It's a shelf-like filling defect, typically at the origin of the ICE, just beyond the bifurcation, secondary to fibrous hyperplasia of the intima, leading to blood flow disruption and thrombi formation. Here, Scone carotid angiogram during the thrombectomy. This is the carotid web over here. In the arterial phase, we can see the shelf-like projection over here, and in the venous phase, we can see the stagnation of the contrast in the lumen. The global hypoxic injury happens secondary to hypoxia whenever the underlying cause to the event that affects that affects the brain cells irreversibly, leading to absent energy. The pattern varies according to the severity and duration of hypoxia which the patient experienced. The brain arterial vasculature was broadly discussed the last lecture. We have to just understand the arterial vasculature of the brain in order to be able to specify the area of the lesion and the symptomatology upon this. The anterior circulation infarction. When speaking in broad terms about the clinical symptoms of ischemic stroke, we have to answer some questions. First of all, is the stroke anterior or posterior circulation? Whether is it large vessel occlusion or not? And we have to seek early detection of the onset. Here, we are broadly putting lines to symptoms of anterior circulation. In broad terms, this contralateral hemiparesis or hemi-hypophasia of the body, including the face at the same side. If the dominant hemisphere is affected, may be aphasia. If the non-dominant hemisphere is not affected, the non-dominant hemisphere is affected, may be neglect. Hemianopia and cortical manifestations may happen. But the diagnosis of posterior circulation stroke is much more challenging due to the unspecificity of its symptoms and may be constitutional as severe headache, nausea, vomiting, blurring of vision. It depends on the anatomical site of the lesion, and it may be or may cause ataxia, crossed hemiparesis, like over here. The patient have one side contralateral to the lesion side weakness, and the opposite side of the face there is affection of the cranial nerves, or the patient may have contralateral to the lesion. Half of the side hypophasia and the opposite side of the face lost sensation, so it's called cross hemiplasia. The early recognition is extremely important. Following the rule time is brain. So fast, the simple scale that can be applied by the patient's relatives or stroke suspected or by the paramedics pre-hospitalization is initially refers to face dropping, arm weakness, speech difficulty, time to call the ER. And there is another scale, updated scale called the B-Fast. They just added the initials of B and E letters. B for the balance, just to conclude some symptoms for the circulation. So for the balance, and E for the eyes, maybe diplopia, maybe blurring of vision. Large vessel occlusion of the proximal large brain arteries of both anterior and posterior circulations, reaching up to A2 and P2 segments. It may be thrombotic, atherosclerotic, as illustrated before. It's very important to pick up the patient's suspicious large vessel occlusions, especially in our developing countries where the investigations aren't widely available in all centers. As this patient diagnosis may need further assessment by CT angiography in the first 6 hours to confirm the diagnosis, or may need MRI brain from 6 to 24 hours of onset to detect the flare diffusion mismatch to be able to estimate the area of the penumbra. The patient can benefit from further emerging treatment like mechanical thrombectomy. That's why the rule time is brain. Large vessel occlusion can be presented by some symptoms that I can suspect that this patient has large vessel occlusion without radiology, like altered consciousness, increased NIHSS score, contralateral complete hemiplegia or hemianesthesia, complete loss of the motor and sensory function, ipsilateral gaze palsy, moderate to severe facial nerve affection, moderate to severe speech affection. Those symptoms may be somehow specific to large vessel occlusions, however, the posterior circulation oftenly don't follow. Here we briefly show the pathognomonic symptom for each of the large vessel, showing the ICA and proximal MCA, the same symptom we just mentioned. For the vertebral artery and the patellar artery, we just said that they are non-specific somehow, like dizziness, vomiting, headache, blurring of vision. But when we talk about the brainstem, it's clogged hemiparesis, altered consciousness, and cranial nerve affection. In the PCA occlusion, causing typically contralateral homonymous hemianopy. CT brain images showing total left ICA occlusion and the lateral artery occlusion, or vessel occlusion. We can see symptomatology according to the anatomical site of the lesion, either in the anterior or the posterior circulation. So, about the anterior cerebral artery supply, regarding the supply the median and superior parts of the frontal lobes and the anterior parietal lobe. Showing the symptoms of dysarthria, aphasia, unilateral, contralateral motor weakness, left limb apraxia. And apraxia means inability to carry on, learn, purposeful movement, urine incontinence, and personality changes. Some CT brains showing the lesion of anterior cerebral artery. The middle cerebral artery is commonly affected artery in cerebral ischemia is supplied the majority of the lateral surface of the hemisphere except the superior portion of the parietal lobe and the occipital lobe and the inferior portion of the temporal lobe. The distal branch support areas which are responsible for speech, the Broca's area and the Wernicke's area for motor and sensory aspects of speech. The middle cerebral artery function, depending on the size of the lesion, symptoms may include complete contralateral hemiplegia.
لا خليك، لا والله خليك، انا هقعد معاك.
تفضل
Regarding the middle cerebral artery infarction, depending on the size of the lesion, symptoms may include complete contralateral hemiplegia, hemisensory loss, aphasia if the dominant hemisphere is involved. The aphasia may be expressive, receptive, or global according to the site of the lesion, and may be in non-dominant hemisphere causing hemi-neglect. There are some CT brains showing the early signs of MCA infarction, including the hyperdense MCA sign, and loss of the insular ribbon sign, and loss of the gray-white matter junction over here. And this CT brain showing extensive MCA infarction exerting malignant edema causing ventricular compression and midline shift. The lacunar infarctions are small due to obstruction of deep penetrating arteries, mostly are clinically silent, and if symptomatic it cause minor stroke symptoms, and S multiplicity can cause vascular dementia. The PCA artery, posterior cerebral artery supply occipital lobes and posteromedial temporal lobes. The CT showing PCA occipital lesion, typically causing visual field defect, which is contralateral homonymous hemianopia due to the occipital infarction. Cerebellar infarction may involve any of the three arteries supplying the cerebellum: superior cerebellar artery, anterior inferior cerebellar artery, or posterior inferior cerebellar artery. CT brain imaging showing cerebellar infarction secondary to different arterial cerebri affection. Over here the ICA and the superior cerebellar artery. Cerebellar infarctions can cause ataxia, can cause nystagmus, may be clinically presented with constitutional non-specific symptoms like nausea, vomiting, headache, dizziness, unsteadiness. That's why somehow it can be missed. For the thalamic infarction, regarding the thalamic blood supply, the anterior territory is supplied by branches from the posterior communicating artery, while the posterolateral, posteromedial, and ventrolateral are supplied by branches from the posterior cerebral artery. Clinical presentation depends on the size of the lesion. The anterior territory and posterior posteromedial territory, decreased level of consciousness, impaired memory, personality change, left hemisphere lesion lead to aphasia, and the right one leads to hemi-neglect. The ventrolateral territory leads to thalamic pain syndrome, and posterolateral territory leads to visual field defects. The brainstem syndromes. The brainstem syndromes have a characteristic clinical picture according to the involved area. However, generally there is ipsilateral cranial nerve palsy affection and contralateral hemiplegia or hemiparesis or hemisensory loss. That's why it's called crossed hemiplegia. There's a rule that can help us to localize the lesion in the brainstem called the rule of 4. The first one of the rule of 4 is that it divides the cranial nerve. Four cranial nerves arise before the bones, 4 cranial nerves arise from the bones, and 4 cranial nerves arise below the bones, from the middle. Number 2, or the rule 2, localize the site of the motor nuclei of each of the cranial nerves, whether medial or lateral. The laterally located are the bulbar cranial nerves, along with the facial and trigeminal nerve, and the medially located are the ocular cranial nerves. Rule number 3, saying that there are 4 midline structures beginning with S, which are the motor pathway, corticospinal tract, medial lemniscus, medial longitudinal fasciculus, and motor nuclei of the cranial nerve. Number 4 states the 4 lateral structures beginning with S, which are spinocerebellar, spinothalamic, sympathetic pathway, and sensory nuclei of the cranial nerve. Here is a diagram showing the rule 4. That's why we can understand the location of the lesion according to symptomatology and vice versa. A lot of brainstem syndromes. For the midbrain, we're gonna illustrate the Weber syndrome. Weber syndrome is a midbrain infarction caused by branch of the BCA occlusion causing closed hemiparesis, contralateral hemiparesis, plus ipsilateral third cranial nerve affection, oculomotor cranial nerve affection causing ptosis and diplopia. Regarding the bones, we are going to talk about the inferior medial pontine syndrome. The inferior medial pontine affection by occlusion of the paramedial branches of the lateral artery presented with crossed hemiplegia, contralateral weakness, plus ipsilateral fixed and sedent cranial nerve affection. So leading to diplopia and leading to complete left lower motor neuron facial palsy at the same side of the lesion. Going to the medulla oblongata, the most important syndrome is the lateral medullary syndrome. The lateral medullary syndrome is the most common brainstem syndrome causing infarction of the lateral medulla supplied by posterior inferior cerebellar artery and vertebral arteries. The clinical presentation here, we can get back to the rule of 4. We are now laterally located in the medulla oblongata. So we have to just apply the 4 rules. The first one is that we have the last 4 cranial nerves arising from the medulla oblongata. Rule number 2 is that we have the motor nuclei of the bulbar cranial nerves located in the lateral portion, which is over here in the lateral medullary syndrome. The third rule is talking about the medial structures, which is not included over here. And the fourth rule is talking about the lateral structures, or the structure in the lateral portion of the brainstem. So over here, the structures affected are the spinothalamic tract, causing contralateral hemihypothesia of the body, the last 4 cranial nerves causing ipsilateral true bulbar palsy, the fifth cranial nerve causing ipsilateral hemihypothesia of the face, so closed hemihypothesia, the sympathetic pathway causing ipsilateral corneal syndrome, and the spinothalamic pathway causing ipsilateral ataxia. Thank you.